department. Mandy will be my backup if I have any technology problems. And we also have several people from Milliman joining us today doing the presentations. Before I go over the agenda and we do some introductions, we're going to go ahead and go over some housekeeping rules. So you've noticed since you joined that you are on listen only. At the end of the presentation, we'll go over how you can ask questions and how we'll take you off mute. However, during this presentation, you can post anything you'd like to chat to us or questions as you think of them in the chat function at the bottom of your screen. We will get to those at the end. As you probably noticed, we are recording this meeting in its entirety, and it's going to be posted along with materials from this meeting on the Rate Reform website page, and we will post that link in the chat for you. And also a notice will go out after this meeting within a couple of days that will include the links to this presentation. And if you would like to sign up for notices, we're going to go ahead and post that in the chat for you as well. So that's all your housekeeping. Wanted to let you know why you were on mute. So today's agenda will be the Milliman team will do some introductions. We will do the MaineCare team slide of who's on your team for MaineCare. Then we will do the rate determination process. We'll discuss the MDFT overview, stakeholder engagement, a survey demonstration, an IRM, so independent rate model. We'll have time for comments and questions at the end, and then we'll discuss next steps. Next slide, please. So I'm going to turn this over to Dennis so the Milliman team can introduce themselves. Thank you.
All right, thank you. And I'm happy to be here. My name's Dennis Finnegan. I'm the project manager and engagement lead for the Milliman team. We're excited to be joining you today to kick off the MDFT part of this rate setting project. For background, Milliman has supported states across the United States and New England, setting Medicaid rates for behavioral health and other community-based services. I'm going to briefly take the time to introduce other members of the Milliman team that are joining me today. Ian McCullough, a principal and consulting actuary who provides oversight and management of the team. Jillian Zahner, an associate actuary and rate setting subject matter expert. And Sasha Wildfong, a child welfare consultant and policy subject matter expert. So once again, my name's Dennis Finnegan. We're looking forward to kicking off this presentation, and I'm going to hand it back over to Jessica to cover the rate determination and main introductions.
Thank you, Dennis. I introduced myself. I am the project lead for this from the Rate Reform team, which is part of Delivery System Reform. But I want you to be aware that there are many other people who won't be speaking to you today that are part of this team from MaineCare. So Henry Ackerson, who is a policy manager, Stephen Fritz he's a policy writer, Dwayne Parsons, manager of rate setting, Dean Bugaj, which is the associate director of Children's Behavioral Health Services, Anita Hood, Children's Behavioral Health Manager, Lori Geiger, who will be introducing herself later. We also have other members that are helping us in this that we don't have on the slide, like Mandy, for example, who's helping us out today and doing my backup. Next slide, please. So now for the next couple of slides, I'm going to discuss the determination process. For the MDFT study determination that we're doing, the next steps and timeline are, we had sent out an initiation notice on July 2nd, 2025. So again, a plug for signing up for notices. I'm going to put that in the chat. So if you don't currently receive notices, you can, and that's how you'd know we were going to start the study, or like that today's process was available to participate in. Then today we're having a kickoff and survey introduction. Later, there'll be stakeholder engagement through the provider meetings and surveys. So you'll have an opportunity, which Milliman and team will discuss today, of how you can participate in our survey. And then we will, if needed, have an additional survey and talk about the results and if there needs to be any clarification to those results. And you would get notification, most likely from a notice, if we were going to have those meetings. Then at the end of all that, there'll be a period of time that we will have to gather some data, and Milliman will do that for us, and find some draft rates. And then we present those draft rate models to you. And then you'll have an opportunity to have a written comment over those models that we will present. And at the end of that period, we will consolidate those and then post the responses to your comments in writing. And those will be posted on the rate reform site that I discussed earlier. And I'll be posting that link in the website. So there's lots of great things there. So at the bottom, there's a little flow chart. So party kickoff, data collection, rate model development, then we'll present the rates, do a public comment period, and then there'll be the finalization of the rate. Next slide, please. So the Maine law is Title 22 MRS 3173-J, which is enacted in 2022, which is a standalone Maine law that says, you know, we will have these meetings. And on this slide, it discusses a few things that really make our process better. So it sets a schedule for regular rate review and adjustment. So we would do annual updates from any rates that we determine off of a benchmark, or if we do it off of other payers, then it will be a biannual review. Non-benchmark rates are if we create our own rate, and those are adjusted and looked at within a 5-year cycle. And then there are times that there are COLAs if you hadn't received another rate within the last 12 months. Then this also ensures a review of relevant state and national data to inform our rates. So that's something Milliman will do in this process. It formalizes clear and transparent process for the rate determination. So as we discussed, all the things that are included in this process. There's also a MaineCare advisory committee, which we refer to as, and they ensure that the program remains effective, efficient, and responsive to the needs of its beneficiaries. And then we also have another part of this process, which is called the TAP, Technical Advisory Panel, and they advise on related technical matters as appropriate and reviews annual schedule of our rate determination. So on the rate reform site, you can find a copy when we do post what studies will be done or rate determinations will be done the following year. And that is approved by our TAP, and we do have a public meeting where we go over that. Next slide, please. Okay, I am now going to turn things over to Lori to discuss the background and MDFT. Thank you.
Okay, thank you very much. Could we just go back to the first, yeah, right there. Thank you. Before we start the slides, I do have a brief background. But before that, let me introduce myself. I am Lori Geiger. I've been working with Children's Behavioral Health Services on the MDFT project for the past 3.5 years under contract with DHHS. Giving you a brief background, in January of 2021, Children's Behavioral Health Services began to work to assess the Maine's existing resources for substance use disorder treatment and support. CBHS was provided with funds from the John T. Gorman Foundation to hire a part-time, not part-time, but time-limited youth substance use disorder specialist. As part of their work plan to address the services and treatment gaps, the department identified several of evidence-based practices for exploration, which included MDFT. MDFT was selected, and the department moved forward on a budget initiative to request funds to support MDFT. Once the funding was awarded, the department began to work with MDFT International on a contract. That contract was encumbered in June of 2024. And at that point, the department then issued a provider interest survey and funding application for MDFT training and certification. So to continue to support the development of MDFT services in Maine, this rate study is presently being performed. OMS intends to add MDFT to the MaineCare benefits manual, and that will allow all willing and qualified providers to be able to offer this service to children and families in their homes. Next slide, please. Thank you. So discussing what MDFT is, what is multidimensional family therapy? It's a developmentally appropriate evidence-based treatment for youth and young adults and their families. It addresses substance use and mental health, and it uses a family-centered approach. It incorporates system of care principles. It is culturally informed and validated. It uses individual youth, individual parent, family, and family community sessions to create proactive factors and decrease those risk factors, which include substance use. Its approach is collaborative, comprehensive, family-centered, and designed to work with diverse populations. It's from youth from 10 to 26, although Maine will primarily is going to go to 21. It simultaneously addresses substance use, mental health, delinquency, violent and aggressive behaviors, and educational challenges. It improves youth, parental, and family functioning. It increases positive peer affiliations, family community connections. It prevents out-of-home placements, and it reunifies families when a youth returns from home. MDFT has proven effective with demonstrated strong and consistent outcomes in 10 randomized clinical trials, which is the most rigorous test of treatment effectiveness. Title IV-E Preventative Services Clearinghouse has rated MDFT as supportive, but MDFT is presently under re-review with them, and MDFT is actually anticipating a well-supported rating. Next slide, please. So why did we choose MDFT? There are a number of reasons here on this slide. It's an effective treatment for both mental health and substance use. That was a really large reason why. It also provides individual therapy for the youth. It also does individual parent or caregiver therapy, family therapy, parent education, and support. It has consistent outcomes of significant and transformative change attained within 6 months. It is also been documented as continued improvement into adulthood. Studies indicate that youth and families who received MDFT maintained and even built on treatment gains for years after treatment. So MDFT has flexibility, and that's a big point here. It can serve young people with a wide array of challenges. It has a very welcoming criterion to work with all families. It does not exclude domestic violence, and it works with parents with substance use and mental health disorders. It addresses family conflict very well also. And more importantly, I think it also broadly defines the parent caregiver role to reflect the variety of family and family situations and dynamics we see out in our communities. These families include biological parents, foster parents, grandparents, and other family members and mentors in guardian roles. Next slide, please. So how does it work? As we've been saying, its approach is collaborative, it's comprehensive, it uses integrative methods. MDFT clinicians provide that individual therapy to the youth, the one-on-one parent sessions, the family therapy. MDFT clinicians and supervisors have a master's degree and are licensed or conditionally licensed, and a certified MDFT team is at least 3 individuals, 2 clinicians and 1 supervisor. It can be a team of 4 therapists or clinicians and 1 supervisor, but usually it is 2 to 1. And although the supervisor can also work as a clinician therapist, or they may just devote themselves fully to supervision. MDFT intervenes systematically, in the 4 connected domains of youth, family, youth, parent, family, and community. As problems overlap, MDFT facilitates change in each of these areas to inspire changes in all of them. It can be tailored to a range of programs. It's been integrated into mental health, substance use, juvenile and criminal justice, and child welfare sectors of care. Sessions are 1 to 3 times per week over the course of 4 to 6 months and in various settings, home, community, and clinic. Maine will be primarily delivered, in Maine, it will be primarily delivered in the home. A mixture may be considered of home, community, and clinic if necessary for the family. So MDFT treatment also can include drug screening. Screening is used to facilitate an open dialogue with the youth about substance use and to move the conversation away from guessing or debating. It also reduces those arguments that can arise from parental accusation or youth denial. It is used as a therapeutic tool to help the youth be honest with themselves, with their parents, with significant others. MDFT drug screening differs greatly from the drug testing and the results used by and for courts, probation, parole officers, and child welfare. Next screen, please. So MDFT's effectiveness. MDFT has proven effective in over 30 years of research and over 20 years of implementation in the United States, and over in Europe. So the MDFT, looking at the MDFT annual yearly report for 2024, the average length of treatment was 5.1 months, with 6.8 hours being the average number of treatment hours per month. So of that, 97% of the families completed treatment, 94 abstained from hard drugs. A big one is 89% of the youth stayed living at home. 83% reported stable mental health. And these are the reasons why we have chosen MDFT and why we are moving forward with it. And I think now it's Dennis's turn to speak.
And thank you, Lori. Yeah, so now we're going to go over, provide an overview of the stakeholder engagement process, which is really a core component of this project work. Today's meeting is the first step in the stakeholder engagement process, and we really do want to encourage your participation throughout this project. So we have three main goals of capturing your experience and feedback. The first is to capture and obtain honest feedback on the service definitions, delivery costs, and payment rate development to help inform those payment rate assumptions. Another goal is to inform providers of the underlying rate assumptions. So there's clarity in what is assumed within the rate models, and also to provide an understanding of potential challenges and identify opportunities to improve service delivery. So as we mentioned, today is the first step in the stakeholder engagement process. We'll also have the provider survey, which is going to capture your experience delivering behavioral health services in Maine. Once the survey closes, we'll go through the draft modeling process, which will look at both the survey results as well as other public industry benchmarks to help inform the draft rates and those assumptions that we had mentioned. And as Jessica had stated earlier, the draft rates will be shared for your feedback and review during future meetings. So we've talked about the provider survey, and now we're going to provide a deeper overview of that provider survey, which really is going to be the main opportunity for us to capture your feedback. So the survey is Excel based. It's intended to collect baseline data to support an understanding of the actual as well as anticipated provider costs to help inform the payment rate assumptions. We're asking anyone providing MDFT services or anticipating providing MDFT services in Maine to complete the provider survey. So we do want to stress that the survey is not limited to current MDFT providers, and the survey is structured to capture your experience as a broader behavioral health provider in Maine. And as you go through the survey, if there are any questions that you feel like aren't relevant or that you're not able to answer, you can skip those questions. The survey, we can go back real quick. So the survey is accessible today and is due by December 5th. It can be submitted via email, and we'll provide the email address at the end of the presentation. The survey is going to capture the service delivery costs, including wages for clinical staff and supervisors, both billable and unbillable time, employee benefits like health and dental insurance, administrative and overhead costs, and any kind of costs associated with transportation. The survey is Excel-based. It can be accessed from this web link in the presentation. The link will also be sent out in a future communication. And this presentation will also be posted to the MaineCare website. So you can go back to this slide and access the web link. And then one thing we also wanted to call out just for clarity is that the survey instructions are embedded within the survey template. And so there's not a separate standalone document. So you'll get to see that there are instructions throughout. So that's an overview of the provider survey. As part of this rate development process, we are going to be using what's called an independent rate model, and Jillian's going to walk through that model.
Thank you, Dennis. So the independent rate model is the model that we will use to develop these rates. This is a ground up approach, which means that the rates are being built from the ground up. They're based on a sum of independently determined rate inputs and components and assumptions. These inputs are based on expected resources that will be required to provide the service and customized assumptions based on provider input. So the main thing here is this is not developed and not tied to historical costs. It's based on actual expected costs in the future. This is a commonly applied method for rate determination for community-based services. Many states use the independent rate model approach, and it is an acceptable model based on the guidance from CMS regarding payment rate development for Medicaid-funded home and community-based services. Some benefits of this approach: it provides transparency as to the reasonable costs required to provide the service. So the The independent rate model will show all of the assumptions and inputs going into the model. It focuses stakeholder dialogue on measurable and objective rate components rather than just the rate itself. We look at all of the individual components of the rate. It supports payment rate updates and modification efforts in the future. It's easy to adjust a single assumption in the future if it increases and that sort of thing. It facilitates comparison of actual costs of providing services, and standardization supports rational relationships between rates for different services. And as I mentioned before, it's not tied to historical costs. It's developed independently from the actual costs that were incurred. So this slide has an exhibit of the independent rate model framework and the components that will be used in the rate model. So the first component is the staff and supervisor salary and wages. So this is including the number of full-time employees that are expected for the service and the hours that they work, the wages of these employees, any adjustments for PTO time or training time that they will be incurring, any overtime costs or on-call costs for these employees, and then also staffing ratios. So this would be the number of employees to a supervisor, or it could also be the number of youth that a clinician is overseeing, those type of ratios. And then employee-related expenses. This is including all of the employee-related taxes and fees, so like Social Security taxes and unemployment insurance, those type of taxes and fees. And then also any employee benefits that are provided by the employer, so things like health insurance or retirement contributions, those type of benefits. Transportation expenses will include mileage paid to employees for use of their own vehicles in delivering the service. And then administrative program support and overhead. This will include basically all of the other operating expenses, so things like management staff, accounting, legal, IT, those sort of expenses. And then for MDFT specifically, we do have a few other cost categories, which includes the evidence-based practice costs. So these are the specific modeling costs that are associated with providing MDFT, and then also drug screening costs, which are a part of providing MDFT as well. So discussing some of the data sources that are used to inform the rate buildup. One of the first data sources is the Bureau of Labor Statistics. This has a lot of valuable information like wage rates, and we can look specifically at Maine and surrounding states by occupational code. It also includes information on workers' compensation rates, retirement contribution rates, health, dental, vision, and life insurance costs as well. And then the Internal Revenue Service can be used to review standard mileage reimbursement rates for reimbursing the employees for their transportation, FICA percentages and limits, and also FUTA taxes. Additional rules and regulations include policies and guidance by the state. This includes the Maine paid family and medical leave regulation as well. And then any additional stakeholder feedback will be considered as well. So this includes technical subject matter expert work groups, survey data, which is what we're going to review today, and then any other feedback we receive from the stakeholders. So now I'm going to switch my screen and we'll jump into a demonstration of the survey. Okay. So when you open up the survey, first you'll see 10 different tabs. I'm going to walk us through each of these tabs and what's being asked on them. The first one is the instructions. So pretty self-explanatory. We have an overview again of MDFT, what the data in this survey is going to be used to support, a reminder of the deadline, which will be December 5th. And then additionally, if you have any questions after this meeting that you need answers to, you can reach out to the email provided on the instructions tab here. That's also how you will submit the final survey once you've completed it, is to this email. The survey in general, you will complete all of the green fields, which we'll walk through on each tab. And there's also additional instructions on each tab discussing what will be in those fields. I do want to note it's anticipated that likely multiple staff members will be needed from your organization to help complete this survey. So just keep that in mind when you're working through completing this by the deadline. You may need to coordinate with a few different people. And then in general, the survey should be reported for fiscal year 2025. So from July of 2024 through June 30th. There are a few exceptions to this, which will be noted throughout the survey. One of those is wages. Those should be a point in time reporting as of July 2025. The glossary here, I am not going to go too much into detail, but this can be used if there's any terms throughout the survey that you may be unfamiliar with. We define those here. There's also a few, you'll notice, links in column C that you can reference as well that have been included throughout the glossary. So moving on to the information attestation, this is the first sheet where you will have to fill anything out. The sheet is pretty self-explanatory. We're asking for provider and contact information in the cells here. And then additionally, we have a question about any behavioral health services your organization provides. So as we mentioned earlier, this survey can be completed by providers that do not already provide MDFT, but are thinking about providing it in the future. So this second question here is asking about any anticipated barriers your organization might have to delivering MDFT services to Medicaid clients. And then at the bottom, we just have an attestation. So just attesting that the information you've submitted in the report is current, complete, and accurate. And you'll note there will be a few error messages, so please complete the section below. If it's not completed, we cannot accept the survey data without an attestation. So moving on to one of the first big data collection sheets. This is the staffing sheet. Primarily, we're asking for information on the clinician who will be providing the service, as well as the supervisory clinician. The data being collected for both of these individuals is the same. So I will just walk through the information for the clinician. The first item is the average hourly wage. And I'll note on all of these tabs, you'll see preliminary assumptions where appropriate. So for example, here we're saying $33.74 is the preliminary assumption, and that is based on the current BLS data for Maine. So we're asking for feedback on this assumption, and we have also included examples of how you could provide your feedback. So if you do not agree with the $33, you could say our average clinician hourly wage is X, and we will use that information to revise the assumption if needed. And then some of them say NA. So as you'll see, the rest of these are mostly NA. That means we don't have a great publicly available source to inform these assumptions. So we're really relying on you all and your feedback to develop these assumptions. So average turnover rate, this is the percent turnover that you're anticipating for the clinician in this role. The average hours per week paid as overtime, and then also the average weekly paid amount for on-call time. I think both of those are relatively self-explanatory. If you do not pay overtime or you do not pay on-call time, let us know that as well, as that's something we'll consider when we're developing the rate. The next couple of items are related to training time. I do want to call out that the first item here is ongoing training time. So this is regular time that you would expect the clinician to be training every year. So this is not including any new hire training when they're first hired. It's just the regular ongoing annual training. The second item is asking for that new hire training without any annual ongoing training. So it's two distinct items there. We are also soliciting input in two different ways. So there's the training hours that are associated with the MDFT model. And then there's also general training like HR type trainings or things like that, that the clinicians may have to do as well that we're asking for input on. And then finally is the PTO and holidays and days on average that would be provided to these clinicians. And then, as I mentioned, all the same items for the supervisor. And then at the bottom here, we have a couple additional free response questions. We're asking what staff types are primarily filling these clinician and supervisory clinician roles. So this could be an LCPC, LCSW, LMFT, psychologist, or a conditionally licensed professional or other. So please let us know who is typically filling these roles or who you anticipate would be filling these roles in the future. So moving on, the next tab is collecting information on benefits. So the first item here is the insurance benefits costs. And you'll notice for all of these, we do have a preliminary assumption since there is publicly available data for most of these items. So please review those as you're giving your feedback. In terms of the insurance benefit costs, it should be noted that this is a single cost, but it's an average of all of the insurance benefits. So it's an average of people that have single employee insurance or people with family insurance. And also it should include employees that do not take up coverage. So let's say you have 10% of your employees do not take coverage, you should factor in that $0 for those people not on the insurance. And then the workers' compensation percentage, this is just a percent of salary for workers' comp. Retirement benefits, similar, is a percent of salary. This should only be including the retirement benefits that you are providing, not the retirement benefits that the employee is contributing. This is what are you as the employer contributing to the employees for retirement benefits. And then the main paid family medical leave percentage, it's our understanding that this can vary from 0.5% to 1%. So please let us know what percentage you are contributing for this. And then additionally, the SUI unemployment insurance percentage. There are a few other items here like SUI, FUTA, Social Security, where we've grayed out the provider feedback column. This is because these are like mandated percentages, mandated amounts. They cannot vary by providers, so we're not requesting any feedback on these, but we wanted you to be aware that they are being considered and they will be included in the rate development. And then we've also included A couple additional rows here at the end, if you have any benefits that you are paying for and providing to your employees that have not been captured above, please let us know about those benefits so we can include them if appropriate. So moving on to the next tab, we have our service-specific assumptions. This is where we get into the more specifics of MDFT and some of the additional costs that are required to provide that service. The first question is asking about the percentage of client sessions performed in home. As Lori mentioned earlier, this will likely be close to 100%. It's not expected that there will be many services provided in clinics or in the community, but please let us know if you are providing a material amount of services outside of the home. The next question is asking about the average caseload assigned to each clinician and any factors that may cause that cause that caseload to vary. We're assuming here 6 to 10 youth per clinician, so that reflects an average caseload of 8. When you provide your feedback, you can provide a range. If it's not always one number, a range is acceptable here. And then similarly for the next question, how many clinicians does each supervisor supervise? This can again be a range. If it's not always one supervisor to 6 clinicians, it can be a range of what is typically seen here or what will be expected. The next question asks about the average number of miles traveled per week by one clinician to client households. So what we're asking for here is round trip. How many miles is this clinician traveling to all of the youth that they're overseeing in a week? And then as a follow-up question to that, is mileage reimbursed for these services and for these employees? And what are the requirements for that mileage to be reimbursed and to qualify for a specific reimbursement rate? And if the answer to that is yes, then what is the mileage reimbursement rate? The preliminary assumption here is the federal mileage reimbursement rate, but we know some states and organizations have different rates here. So if you vary from the federal, please let us know. The next question is the approximate percentage of no-shows and late cancellations. This is a no-show or late cancellation counts as any service that has been canceled within 24 hours of the time the appointment was supposed to originally occur. And then finally, the last 3 questions here are all related to drug screenings as a part of the MDFT service. So we're asking 1, what is the average cost of a drug screening kit for your organization? And then how many tests are in that kit? So the example here is $141 with 25 tests in the kit. And then how often are the clients undergoing these drug screenings? Is it 1 test per week, 2 tests per week, etc.? So that's it for the service specific questions on the MDFT side, and then we jump into program cost questions to make sure that we're capturing all of the different program costs for MDFT. The first question is related to any facility costs. If there is an office or facility, what is the annual cost to your organization? And also we're asking for how many square feet is that, so we can review these answers based on a per square foot cost. And then the next one is any program expenditures for service related licensing fees. I will I'll back up a little bit too here. A lot of these items here are defined on the glossary as well with a lot more specific examples. So if you get to this section and have questions about, well, what's a program expenditure for service related licensing fees, all of those are on the glossary and there's more detail there. And if anything is confusing, you can always reach out to the project email as well. The next two emails are related to the modeling costs for the evidence-based practice. Again, similar to the benefits, these ones are grayed out because these are pretty much set modeling costs that are not going to vary. So we're not looking for any feedback there from individual organizations. And then the last couple of items here, if you have any program support staff, so for example, a therapist assistant, what are their program expenditures? So basically their salaries. I do want to note this should not include administrative staff. So this shouldn't include like legal staff, HR, IT. That's separate staff members that should be included in this row here for the administrative and overhead costs. So this should be a percentage of all of your expenditures and should include essentially everything that has not already been included or asked about elsewhere. However, we have included a few additional rows here if you have any other non-billable costs related to MDFT that have not been captured elsewhere and you want to explicitly call those out. We'll review those as well. And then moving on, these last few tabs they're optional. This is tab 7 is for any additional information. On any of the tabs, there's also just miscellaneous comments. So if you have any additional information about staffing that was not captured on the staffing tab, but you want to be considered, this is the place to enter any of those notes. The next tab is just general survey feedback. If you have any feedback for us to improve future surveys, anything maybe that was confusing or you wish we had included this or done XYZ, this is the place to enter any of that kind of feedback. And then the last tab really is just, we call it a scratch pad. Anything submitted on this tab will not be used for any reason. So this is really just a place for you and your organization to do any scratch notes or math or anything you want to do here. But that is pretty much it for the survey. So I am going to stop sharing, reshare our deck. So yeah, go ahead, Jessica.
I'll take it again. Thank you, Jillian. That was amazing. And thank you for walking through so clearly for each thing. And hopefully that will help everybody on the call. So we have been monitoring the chat. And so we haven't received any chats up until now through the presentation, but I will call out that we've been posting some stuff in the chat that might be helpful to people who have joined us. So again, in the chat is the link to get to our rate reform system website where you'll be able to look up the information. So if you're waiting for the notice, sometimes it's there before the notice goes out. So that's a helpful tip. And then again, about the notices, if you aren't signed up for notices, the link is there for that. And then also Dennis has posted in the chat the email address that you'll need if you have any questions from today. That will also be included in the information that will be sent out in the notice. But in case you want to copy that link down now, you'll have access to that immediately. And then also Dennis has posted in the chat the link so that you can start the survey, which again will go out in the notice, but this will kind of give you a head start. So we have reached the portion of our presentation that we'll hand it over to you guys for questions or comments. But before we open it up, I just want to go over a few more housekeeping or how this works. So if you have a question, raise your hand, and that is found virtually. Your virtual hand is at the bottom of your screen. And then if we have multiple people with their hands raised, we will call on you in order that they're raised. And so that is the participants or reactions at the bottom of the screen to raise your hand. If you're participating by phone, select a *9 to raise or lower your hand. Keep your hand raised until you're called on. If you're on the phone, we use the name that we're seeing on the phone number. I'm not sure if I have any phones today, but just in case. And then you would hit *6. Once we unmute you, or will request you to unmute, begin your comment. Please, it's helpful to us if you can state your first and last name, what organization you're from, and how you represent your affiliation. And then I don't think this is going to be a problem, but I just ask people sometimes to keep their comments to a limit to allow everybody else to have time to ask their questions. So if you don't mind, Jillian, I think for the moment, we're going to drop this down and then we can see people's faces, and it'll be easier for me to tell if anybody has their hand raised to ask a question or a comment. And don't be shy. That's what we're here for. And we have a whole nother hour dedicated to this. So is there anyone who wants to raise their hand, has a question or comment, or wants to post something in the chat? Let us know. Oh, good. Okay. Christy, I should have given you permission to unmute yourself.
Yeah, thank you. Sorry, I can't show my face because my video is also disabled. I was wondering, with some of the other programs that we have looked at, there's been data to show in regions of the state how much need there is. I was wondering if there's anything that shows how much need in certain counties or areas of the state there is.
And do we have somebody on the call who can field that question?
Hey, Jessica, it's Lori. What I do know is Children's Behavioral Health Services was looking at identifying from their wait lists possible areas where there could be larger demand. And I have to say that I have not seen anything come out of that, but I'm not saying that there isn't anything, but I can check.
Thank you, Lori. Is there a way, Christy, do you want to post your email in the chat? And there might be a way for Lori to communicate back to you. And I'm not seeing any other hands raised or nothing in the chat. I want to give it a minute because I want to give everybody an opportunity to join in asking your comments. And absolutely know that if you think of questions later or might have been a lot of information presented, and you will have that opportunity to review this recording. You will have an opportunity to review the PowerPoint presentation, and you will have access to these links through the notices. So if you're thinking of questions later, if not today, let us know. Oh, Christy, I'll get unmuted again.
Thank you. Sorry. Yes, I was unmuted again. And just so you know, the chat is disabled. So,
Oh.
that's why, and I apologize. I'm the
Oh,
program officer at Sweetser. So I appreciate that. And I can certainly get in touch with Anita, I think, for any follow-up. But I appreciate that.
okay. That's weird. On my end, it doesn't say it's disabled.
Not disabled at the bottom of mine, but I appreciate that. Thank you so much.
Okay, well, I apologize for anyone that it's not working. On my end, it looks like I've given that option.
Well, maybe we should try unchecking it.
I will do that. Okay. So hopefully we just unchecked a button. Maybe that will work, but there are other options after this meeting to contact us with questions or Milliman with questions. And again, I apologize if that chat's not working. Can people see what we posted in the chat though?
Yes.
Okay. I'm not sure. There's usually a glitch or something at the meetings, technology wise. So does anybody have any questions? We do have time. Or I hope everybody feels comfortable that they have a way to communicate back out. Where we're ending earlier today, I'm hoping that our recording will be done in time, that potentially it will go out today. If not, it will probably go out Wednesday. So you can expect that this afternoon, or Mandy, you're going to say, go ahead.
Yeah, I'll be able to post everything to the website this afternoon. But so they'll have access to the materials. They just might not go out in a notice until Wednesday due to the holiday tomorrow.
Right. So if you feel like you might want to get started in on some of these things today, if you copy what we have in the chat, that will help you because it will be at the bottom of the page. I don't see any more hands raised. So calling once or twice for hands, and then we're gonna, Dennis, do you have something you'd like to say to finish us at the end?
Yeah, I think if we do have just we had a next steps, but I think just generally, yeah, it's everything that we've put into the chat. So wanting to remind everybody, and just a very much appreciation for everybody, taking the time to attend today's meeting. Hopefully you have access to the email address in the chat as well as the survey. So we've included that web link, but as we've mentioned, that'll also go out through the upcoming communication. We do ask for surveys to be submitted by the 5th of December. And generally, if there are any, I know the email communication will also be in that in the provider notification that'll be going out, but we've also included this email address, for any kind of questions that you may have. And I think just again, really appreciate everybody's attendance in today's meeting, and I think this is a big, happy to reach this milestone in the project.
Thank you, Dennis. Well, no hands, and apologies for whatever's happening with our chat. And thank you everyone for taking the time to join us today. We really appreciate it. And we appreciate you being involved in this process. And as we move forward, we will continue to engage with your participation. Thank you so much and have a great day.